Pig's feet are needed for the laboratory exercises. Pig's feet can readily be purchased in any grocery store in the butcher section. This is an example of assorted pork hock feet and neck bones. The pig's feet are used because of their similarity to human skin. Pig's feet are usually individually wrapped and can be stored in the refrigerator. Be sure that they are sliced in half so that they lie flat. In addition to the pig's feet, the remainder of the equipment is as follows: 2 heavy rubber bands, dissection tray, surgical towel, suture, forceps, scalpel handle, skin hook, scalpel blade packaged, surgical marking pen, needle holder, also called needle driver, tissue scissor, suture scissor, hemostat, and surgical gloves not shown. After the pig's foot has been prepared, take the surgical marker and mark a line of approximately 6 to 8 centimeters in length on one side of the pig's foot. This will be the site of the incision. Then, with the number 15 scalpel blade on a scalpel handle, begin the incision, holding the blade at approximately a 45-degree angle. Begin this incision down through the skin into the subcutaneous tissues. Proceed with the development of the incision for the entire 6 to 8 centimeter length. A number 15 blade is used to begin the undermining, which is to separate the skin from the subcutaneous tissue. In order to allow the tissues to come together during closure, undermining is necessary. The scissors is used to undermine the tissue, and tension is created with the forceps. When scissor dissection is used, the tips of the scissors are best kept up towards the skin edge so that a deep structure is not inadvertently cut. A number 15 blade is used to continue the undermining. This undermining, which allows closure without tension, is usually carried 1 to 2 centimeters beyond the incision site. The first suture or central suture is placed midway between each end of the long axis of the wound. The second suture is then placed, according to the principles of halving, midway between the central suture and the end of the wound. The simple suture is being placed. The needle is always driven at 90 degrees or better to the skin edge. The simple instrument tie is shown in this case. If one places the needle driver between the 2 suture strands, always rotate the strand with the needle on it towards the free strand and pull in the opposite direction. This will always put down square knots. The tied suture is trimmed with a small tail to prevent unwinding of the suture during healing. Here the skin edge is being grasped for placement of a vertical mattress suture. The first sutures are placed close to the skin edge in the intradermal plane and are used to oppose the epidermal or skin edges. The second throw is placed on a line formed by the first throw, but approximately 4 to 5 millimeters posteriorly, and placed full thickness through the skin. It is then pulled through to take the tension off the epidermal or skin edges. The free suture edges are closed, and one can see the resultant eversion of the skin edges with this suture technique. The skin edge eversion is one of the keys to getting good wound healing without broadening of the scar or producing a hypertrophic scar. The horizontal mattress suture is placed much like a simple suture on the first throw. Then a simple suture in the opposite direction for the second throw to get the resultant 2 throws and a loop across the wound. The edges are then sutured together. In this suture type, there is no free edge of suture crossing the external wound edge margin. The running suture is started by placing a simple suture at the end of the wound and keeping the long end attached to the needle uncut. Subsequently, simple sutures are placed across the wound with care not to lock the suture into the loop of the free end. The constant tension is held on the closure posterior to the next throw by the assistant to prevent loosening of the posterior sutures during the subsequent closure of the rest of the wound. At the end, the final throw is placed but not pulled through entirely. The loop on the second to last throw is utilized as a single strand and tied down to those 2 loops from the one free end. If one grasps centrally inside the looped 2 strands, it allows even pull on the suture end for closure. Running sutures can be removed by grasping and snipping each subsequent suture and pulling through. The running locking suture is started the same as the simple running suture, but in this situation the suture and each subsequent suture are brought through the resultant loop of the free end of the suture and the needle end. This results in a lock-type suture on one side of the incision. Again, an assistant can hold traction on the free edge of the suture during suture placement to keep sutures that have been previously placed snug and in position. The running locking suture results in better eversion than the running simple baseball suture. At the end of the running locking suture, the knot is tied down to the free loop edge of the previous to the last suture placed. The running intracuticular suture is placed first by bringing the first suture in a line parallel to the apex of the wound into the soft tissue and then out the intradermal layer of the apex of the wound. The first throw is placed entirely in the intradermal layer of the skin just beyond the apex of the wound. The next throw is placed opposite this and slightly overlapping, but not entirely overlapping the first throw. Subsequent throws are placed back and forth across the wound. The last throw is brought out the apex of the opposite end of the wound. The wound is further closed with steri-strip taping. The free edges of the intradermal closure are taped down snugly. Steri-strips are placed across the wound to prevent further tension on this closure during healing. Proper removal of the steri-strips necessitates using an adhesive remover, peeling the steri-strips towards the wound, and pulling straight up at a 90-degree angle to the long axis of the wound itself. With the intradermal intracuticular closure, the tape over the ends of the suture are then removed, and the suture removed with a gentle, constant pull on one end. In the staple closure, the wound edges can be everted with a set of forceps. If an assistant is available, 2 sets of forceps can be used to evert the wound edges. The staple is placed and squeezed into position, resulting in good tissue eversion. It is helpful to have one person everting the wound edge while the other person staples, as this will result in a more controlled closure. The preparation of the laparoscopy tie. The end of the suture has a clip applied. That clip is used to prevent the suture from passing completely through the tissue. Now the needle driver is inserted through the tissue, it's regrasped, and the suture is pulled through. The clip at the distal end of the suture then prevents the suture from completely passing through the tissue. The ties are continued as the suturing ensues through the tissue in allowing closure of a particular wound. After the wound is sutured closed, the distal end is now also clipped, which prevents the suture from coming loose. This is a technique that is very advantageous when operating through the laparoscope. Note the clip is now applied to the now distal end of the suture. It is then drawn down to the surface of the tissue and clipped in place. The distal end of the suture is then cut and the procedure is completed. Note the cutting of the distal end of the suture, completing the closure. Low tension wounds can be closed by gluing the skin edges together with a skin adhesive. These skin adhesives are best used or applied in 2 to 3 layers. The applicators are usually in 2 types. The original is the dome tip applicator. The newer applicator is the chisel tip applicator. These chisel tip applicators can be used either in a broad or narrow application of the skin adhesive. Note the broad and wide application, usually in 2 to 3 applications, to allow the wound to approximate and heal. And note also the narrow application when you rotate the chisel tip at right angles to the previous direction, and this allows a nice thin line of skin adhesive application. The fusiform excision is marked with a length of 1.5 to 3 times the width. The intervening skin and soft tissue is then excised. The incision made in the skin edge should be perpendicular to that skin edge. The fusiform to be excised can then be removed with sharp dissection using either knife or scissor. The skin to be excised can be held with a forceps or a skin hook. The middle finger can also be used to aid in the retraction of the soft tissue during the dissection. In order to allow the tissues to come together during the closure, undermining is necessary. When scissor dissection is used, the tips of the scissors are best kept tip upwards towards the skin edge so that the deep structures are not inadvertently cut. A number 15 blade can also be used to continue the undermining. This demonstrates that either a scissor or a number 15 blade can be used to undermine the soft tissues, which will allow closure without tension. The first suture that is placed is a deep suture, and it is buried. It is placed in the dermis at approximately the mid-portion of the incision, according to the principles of halving. A surgeon's knot is used to close the deep tissues, thereby approximating the wound edges. Notice how the wound edges come together. The deep suture is cut on the knot, and the wound edges are now well approximated. A second deep suture is placed according to the principles of halving, midway between the first central suture and the end of the long axis of the wound. Again, an instrument tie is used to fashion the square knot. 4 throws are used to be sure that the knot is secure. Skin sutures are then placed according to the principles of halving. The first or central suture is placed midway between the long axis of the wound. Note that the edges of the wound are both approximated and everted. The skin suture is cut with a tail. The remainder of the skin sutures are also placed according to the principles of halving. The advancement flap is drawn so that the length is approximately 2.5 to 3 times longer than the width. Care is taken to stay in the subcutaneous plane during the excision of the lesion. Countertraction is helpful during incision and excision. The scissors can be used to undermine as well as to cut the deep layers of the soft tissues. The skin incisions themselves should be made with a sharp knife. Care is taken to incise perpendicular to the skin edges. Again, the entire flap is undermined in a layer between the skin and the deeper subcutaneous tissues. Undermining is continued beyond the extent of the dissection by 1 to 2 centimeters in all directions. This allows for easier flap mobility. The first suture is placed in the center of the flap and out the central aspect of the defect. This is tied with a hand tie and a surgeon's knot to prevent slipping of the knot. By keeping constant tension on the sutures, one can prevent tying an air knot. The suture is cut with a small tail that prevents unwinding of the suture material over time. The corner sutures are placed next, since they are the other primary sites of tension in this flap design. Here an instrument tie is being utilized for the corner stitch. Again, a surgeon's knot is put down on the first throw, and now we have a problem of unequal skin edge length. The skin edge is longer than the flap edge. We will then close this with the principles of halving. The first or central suture is placed in the middle of the inferior edge of the flap and in the middle of the corresponding skin flap. The 2 halves on either side are still uneven, but less so. Subsequent sutures are then placed so that it splits the difference between the previous sutures until enough sutures are placed for adequate closure. In this way, the redundant skin of the lower flap is spread evenly across the entire wound closure and results in a smooth wound edge. On the upper flap, we have closed it so that the skin is closed in an even manner, resulting in a standing cone deformity at the inferior aspect of the flap. The standing cone deformity excision is always done away from the flap pedicle. A single hook is placed in the dog ear, and the triangle that is formed can easily be seen. It is then marked with a surgical marking pen. An incision is made perpendicular to the skin edge so that we can mark out the point of a triangle. Undermining is done under this dog ear deformity. The skin is transposed back until one can exactly see how much skin is needed to be trimmed. The skin is then trimmed and the flap is inset. This flap is then sutured into place and the dog-ear deformity is resolved. The rotation flap is utilized to close a triangular defect. The rotation flap follows a smooth curve from the site of the defect. It then gets rotated into place. Typically, the limb of the rotation is approximately 2 to 4 times longer than the axis of the defect that it needs to close. This is a flap with a very large vascular pedicle, and it is extremely useful for facial reconstruction. Because the skin edges have already been incised, the defect can be completely excised with scissors. The flap is then incised with a knife, broadly undermined under the entire flap, as well as 1 to 2 centimeters beyond the skin edges of the defect. Test rotation can be done intermittently during flap elevation to determine whether the back cut is enough. The key suture is then placed. An instrument tie can be used with this flap design because there is not a significant degree of tension. The flap edge is then closed to the longer skin edge using the principles of halving, splitting each side in half for subsequent suture placement. The Z-plasty is useful in lengthening wounds as well as reorienting the direction of scars. In this example, the central limb is 3 centimeters at the start of the incision. The limbs are the same length and both come off at approximately the same angle off the central limb. The angle varies anywhere between 30 degrees and 60 degrees. The greater the angle, the greater the gain in wound length. Any sharper angle or smaller angle results in risk of tip of flap necrosis, while a broader angle results in a difficult rotation. Here the flap is being held out of the way with a skin hook, and the skin is being elevated with a sharp number 15 blade. Each flap is then grasped with a forceps and transposed across so that the central limb totally reorients by 90 degrees in this example. The width of the defect increased from 3 centimeters to start with to 4 centimeters in result, demonstrating the lengthening effect of the Z-plasty. The corner stitches are placed into each flap first to transpose them. Remember, always transpose the Z-plasty. If it closes as it was initially incised, then it will have no effect. The limbs of the Z-plasty are closed with multiple sutures. Here we see the defect. An incision is being made around the defect, and then the limbs of the note flap will be created by making a line as a tangent approximately